can. Let's go live on Facebook. Alrighty then. Let's see here. Hello, 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 my friends. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, June 5th, and it is yet another time for another live support group meeting. I will tell you that I'm not 100%. The allergies this year are sick. Like what the heck is going on with allergies this year? I'm even going to have a CAT scan of my sinuses in a week, because they're just crazy. Hi, Deborah. Nice to see you. So anyway, listen, my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network, doing a national IC support group meeting. I try to do these every Sunday. Couldn't do it last Sunday. Got to get this whole sinus thing under control because the headache is real. But anyway, I love coming on and giving you support. We get a lot of really nice phone calls and emails afterwards. And I want to thank everybody who reaches out to me and says that they find these meetings helpful. You know, ultimately, that's my job. My job is to show you that you're not alone. My job is to hopefully give you some comfort, right? To give you some, a much needed hug over the internet, to let you know that somebody's here for you. I am here for you. I never want you to feel like you're alone in this, because you're not alone in this. You know, Diana Ross was performing at the for the Queen, and I watched the video last night, and she sang that song, I'll Be There. I'll be there. And that's how I feel about the work that I do, is I want to be here for you as much as I can. And so, but I'm not a doctor. It's not my job to give you medical advice. My job is hopefully to give you context, to give you new information, to give you new resources to look at, to give you that much needed kick in the pants. You know, I mean, at least once a week, And because I usually work with 10 patients a day and through the IC network, through my phone line. And at least once a week, somebody calls and they're struggling with really severe symptoms. They've got the frequency, they've got the urgency, they've got the pressure, they've got the pain. They've seen lots of doctors, they're not getting better. And we go over the basics, you know, it's like, all right, now we have to understand what your anatomy is. We can't really talk about treatments until we understand your underlying dysfunction, right? Because we don't want you to do bladder therapies if your pelvic floor is the issue. We don't want you to waste your money on pelvic floor therapy if it's really your bladder and you've got chemocystitis, something like that, right? So whenever you work with me in a coaching session, or even not in a coaching session, I always focus first about anatomy. I really don't want to hear what you've done yet. I have to try to visualize in my brain what could be happening with your body. And I will ask you your age. How old are you? And then how old were you when your symptoms first began? And then tell me a little bit about what was happening back then. What was happening when your symptoms began? And I was working with a lovely man. I think I told this story when I did our Thursday drop-in meeting, whose symptoms started as a teenager. And he was now in his, I think, early 70s. And he had symptoms for 50, 60 years. And nothing worked for him. Bladder therapies didn't work. Neuromodulation didn't work. Oral medications didn't work. Nothing worked for him for decades. And he was obviously at the point where he was sick and tired of this. Fix this. Please, God, fix this. I want a normal life, which is how we all feel. Please, God, fix this for me. And so, you know, and we have our new AUA guidelines, and our new AUA guidelines say, hey, if you're not responding to therapy, take a step back and revisit the diet. It's okay, Donna, it's fine. Revisit the diagnosis. Let's make sure we understand what's going on here. So anyway, I bring him back into his teenage years. And it's like, all right, tell me what was happening back then. He goes, well, I knew even when I was in high school, when I would go into the bathroom to pee, that other guys could pee a lot. I couldn't. I was always stopping and starting and stopping and starting. And I was like, okay, were you involved in sports? And he goes, yeah, lots of sports. In fact, he was a baseball player for decades. And he said, we did a lot of sliding. We did a lot of falling and sliding into home base and into our various bases. It's like, okay, interesting. Of course, I asked him that all important question. When you go to urinate, can you start your stream right away or do you hesitate 5, 10, 15, 20 seconds before you can release urine? And of course, his answer was, no, I hesitate. I cannot pee right away. It's always been that way. Oh, and so I'm going, this really, in my brain, I'm going, sounds like pelvic floor. Sounds like pelvic floor. Bladder therapies didn't work. Interesting. So then I said, you sound a lot like me. My symptoms started when I was a teenager. And I had something called a urethral stricture, where it felt like I was trying to pee through a needle. That my urethra was so narrow, it was hard to urinate. And he goes, yeah, that was my diagnosis too. And he said it was so severe that they actually did surgery. They actually sliced his urethra in 2 areas to expand its capacity. And of course, for me, I had what we call urethral dilations, where they just stick a rod, or they call it a sand, up into your urethra and stretch it. They do ever expanding sizes. And back then, that was what they did. Well, I said, the flaw with that thinking is that nobody ever asked, why is my urethra narrow? Why is my urethra narrow in the first place? What could be causing that? And he was like, yeah, I never really kind of understood that. And I went, well, we know what causes that now. We know what causes that is the pelvic floor. It's like, really? And I went, yeah. Now think about it. You were heavily involved in sports from the time that you were a teenager, just like I was. And what we know, the biggest risk factor for pelvic floor dysfunction, especially in childhood, is a history of sports and history of recurring traumas, even mild traumas over time. You slide once, you get a little trigger point, you slide the second time, you get another trigger point, you slide a third time, maybe you don't get a trigger point, but you're sliding dozens of times through your teenage years. And eventually what happens is those muscles become so injured that they get tight. They get tight. And he's like, yeah, I always wondered if that was the problem. And I went, well, have you had a pelvic floor assessment? And he said, no. And I said, it's time. It is time for you to go have a pelvic floor assessment and let's see what else is going on. And luckily we found a board certified, not board certified, a Herman Wallace pelvic certified physical therapist literally in his small town. So anyway, when you work with me, I always like to go back in time, but I wanted to get back to the other point that I was going to make. There's always somebody who they know they're IC subtype 2 bladder wall driven because let's just say they have estrogen atrophy and they're still drinking coffee. And they're still drinking soda and they're still drinking orange juice. I was working with one lady who was drinking lots of orange juice every day and lots of coffee every day. And obviously her symptoms were completely off the charts. And, we're kind of backslide into this discussion. And eventually I go, okay, you know about the diet, right? You're following the diet. You clearly have estrogen atrophy. Your bladder wall is vulnerable. You're not drinking any coffee, are you? And they hedge. And they're going, no, I'm pretty good with the diet. And I'm like, no, seriously, what are you drinking? And they go, all right, you caught me. So anyway, my job is to educate, empower, inform, and give you that good old fashioned kick in the butt when you need that kick in the butt, right? All right, Donna. Oh, honey, your oldest son was just diagnosed with stage 3 colon cancer. I'm telling you, as Donna said, you know me, I'm so positive because that's me. Sometimes you don't choose the issues choose you. Yeah, isn't that the truth? You know, it's funny because I worked with several cancer patients this week too, and it was just something that just I wish I wish that things weren't so complex. I feel like we're all getting pounded on right now with stress, you know? I just feel like we're all getting pounded on with unpredictable, challenging nuance. Another patient that I talked with on Friday, I talked, now this is very interesting because I talked with her many, many times over the years. And I hadn't heard from her for about a year. Um, and she called and she was absolutely exuberant. I mean, the first time I really heard joy in her voice, and it's like, "How are you doing?" She goes, kind of the same old, same old." And then she said, "But you know, I had cancer. I went through this major cancer scare." But no, it wasn't a scare. She had cancer, and she had to have major surgery for it. And in the process of coming out of that surgery, you know, it gave her context that that she was joyfully alive, and it had completely changed her. And she said, "Yeah, all my friends are saying I'm happy now," and I'm like, "Yeah, you are so different now." So I'm hoping, Donna, that this will be a moment of challenge. Yes, it's going to be challenging, difficult, scary. We've all been there. God forbid we've all been there. But perhaps on the other side of this journey, there will be closeness and joy in the simple things in life and joy in our relationships and all that sort of stuff, you know? Caroline, hello from England. I was watching at 6 o'clock this morning. I woke up at 6 and I was watching the big parade for the Queen for a little bit before I went back to sleep. All right. Now, all right, Facebook, you guys are being challenging here. Hi, Ruth. Hi, Ann. Sue says, water, water, water. I have herbal coffee, herbal coffee. Carolyn says, I've been referred to a new young urologist after having the same urologist for 15 years who finally who finally admitted he doesn't know much about IC. Oh, you know, the arrogance, right? I mean, listen, we all have ego. We all want to look good. Doctors certainly want to look good. It takes a tremendous amount of humble pie to admit to a patient that you're outside their skill set. And if they're not willing to devote the time, then it's absolutely right to go to somebody else. You know, here, hold on a sec. Look at this. This is where my life has been the last 3 weeks, is diving through all these new guidelines. And it is so, and if you go to the IC Network website, our first blog is on these brand new guidelines for IC, and I'm happy to talk about those. I put a link not only to our 5-page fact sheet, but I also put a link to the actual AUA guideline document. And I think it's very, very important that you print out 3 of these. And yes, it's long. Yes, how many? Well, hold on. There's an article in the back of that. How long is it? 50 pages. Okay. Seriously, print out 3 of these. One for you that you need to study. You need to understand how doctors are supposed to be interpreting these guidelines. Number 2, one for your doctor. Because guess what? They don't even know these guidelines have been released. They don't. We are educators. Embrace your role of being an educator. Embrace your role of being an advocate. Your job when you work with your doctor is to make the journey easier for the next patient behind you, right? We never want to go, we never want to create a bad image for the IC patient because we already face too many obstacles. And so you always want to treat your care providers with kindness, compassion, caring, and honesty. And at the same time, if they're obviously not knowledgeable, then it's okay to move on, but don't make the IC community look bad. So print one of these out and give it to your doctor. And then you always want to carry a spare in your car. So if you have to go to the emergency room or you have to go to somebody else, you can walk these in with you, because nobody can then say that this is all in your head. Nobody can say this is not a real condition. Nobody can say that there's no treatment. There's a ton of treatments available. And the new guidelines embrace subtyping, my friends. They'd say that IC is not a bladder disease anymore. IC is a chronic pain syndrome. Why? Because structures outside of our bladder are often involved. What is this? Look at that. Holy moly. I have got a streak of white right there. I normally don't have my part right there. This is a super casual day, guys. Super casual, super easy, happy, fun, joyful. Okay? Rada says, that's so true. I had so much urethral burning for 2 years and it went away. I wasn't sure if this was Urabel or Amitriptyline out, but it makes sense now. Physical therapy helped. Hello, Pam from Mississippi, the great state of Mississippi. Caroline says, I've asked my new urologist in a very big city, supposedly known for their research with IC. I asked him if he could figure out what subtype I have. The new doctor here said that here in Canada, they don't believe in subtypes. I'm so defeated. Listen, okay, so in Canada, so to be picky, he's right and he's wrong. Okay, in Canada, you guys are supposed to be using a system called U-Point. And U-Point is where doctors assess you in 7 specific domains. So they create literally a unique subtype just for you. And so they're supposed to check what your urinary symptoms are, what your pelvic floor tension is. Do you have any other neurologically related pain conditions? Do you have any presence of infection? Do you have presence of depression and catastrophizing? Because God knows we absolutely have to work on that too. And then there was a new one that they just added that started with an S. And I don't remember what that S was. Was it somatic? Oh, sensitization. So now it's U-Points. So if you look at the guidelines, the IC guidelines in Canada, as well as the new IC guidelines that were released by the European Association of Urology, they use U-Point. And so U-Point is probably better than the subtypes that we're kind of using right now, because it really allows for a customized diagnostic workup. Here, hold on a sec. Where is my EU guidelines? Oh, I have a consumer warning too. So I'm doing a side project here. And here it is. Do you know that chamomile, we always say chamomile herbal tea is like the one tea we really want you to try because it's known for being the most calming and soothing. And God knows it is, and the research supports that. But chamomile does a lot more good things. And I'm going to be doing a little bit more information on that. Once I got into some of that nutraceutical information and that herbal information, I was very, very surprised by what chamomile actually can do. And I think we're going to be using it a lot more. And that's all I'm going to say about that. But anyway, in the U-Point system, let's see, I have it. So I am now referring to, these are the new guidelines released by the European Association of Urology for chronic pelvic pain. And let me just get this correct. Oh, no, I'm wrong. Okay, so S was not sensitization. They put the sensitization under the neurologic category. S stands for sexological. Does this patient have erectile or ejaculatory function or dysfunction, arousal, lubrication, or post-orgasm pain? So I was wrong. So anyway, ask him to do U-Point because those are in your guidelines. I understand that this is all very fluid and dynamic, but we're absolutely moving in the right direction here. All right, hold on a sec. I got to turn on my air conditioner. Yes, Thank you. This little tiny air conditioner right next to my. Okay, am I together? I have to be together here to talk to you. Okay, I think I'm together. Okay. Hi, Vicki. Sherry, Sherry says, I have another new doctor appointment with Dr. Gary Womack that one of the other listeners told us about last week if you live in Dallas. So I hope he is familiar with pudendal nerve entrapment subtype 4. Pray for me. I will, honey. I absolutely will. Remember that so the thing that you've got to pound away at him about are your positional symptoms, because these are not associated with your bladder. If you have sciatica, pain that shoots down your leg, if you've got persistent genital arousal disorder, areas of pins and needles, or numbness, those are all signs that you have a nerve that is compromised, usually by tight muscles. And so, don't go in and say, can you please diagnose me with subtype 4? Okay, that's not helpful for them because they might not know the Chris Payne system that we use. But instead, what I want you to do is just pound away at your symptoms. Walk in and really clearly describe them. And don't even say interstitial cystitis at first. Why do I have pain that when I sit down that hurts, that when I stand up it gets better? Why do I have pain that shoots down my leg? Why do I have tingling in the bottom of my feet? Et cetera, et cetera. Jeannie says, I had a really bad night last night. It took so long to urinate and was in a lot of pain. When I did urinate, it was blood and 2 nickel-sized blood clots. I have Hunner's lesions. I'm waiting to see the doctor in New York in a few weeks. Should I be concerned about blood clots? Absolutely. You need to call your doctor tomorrow. You need to call your doctor tomorrow, even today, and leave a message and talk to the on-call doctor. That is not okay. Number one, the challenge with the blood clots is if you get too many in them, they could actually block your urethra and you might not be able to pee. But more importantly, something's bleeding and we need to figure out what the hell is bleeding. You either have a UTI or your Hunner's lesions are bleeding, or maybe it's even something else. So I do not believe you should wait. I think you should call your doctor today or at the earliest or tomorrow morning. Okay. I consider that very, very urgent. And I don't know any doctor who would disagree with that. You're passing blood clots, that's considered urgent. Hi, Boria. Hi, Caroline. Hi, Vicki. Vicki says, I didn't know about the tingling the feet. Yeah, it started for me in my 20s. I distinctly remember, because I have a slight pudendal nerve entrapment on my left side, by my left SI joint that's all messed up, right? And so I can remember I used to love to read on my couch, where you're kind of laying down on your couch and you got your head tucked up with pillows, which of course massively screws up your neck. But back then I didn't understand that. And I would notice that my feet would start to tingle. And it kind of freaked me out. And then I started noticing that my feet would tingle, but then I would need to go to the bathroom and have a bowel movement. And then I completely saw cause and effect. And that's because, when you think about the pelvic cavity, the small pelvic cavity, the nerves and blood vessels that go down your leg actually have to pass by your lower intestine and your rectum. And so if you've got something hard and pointy or bulgy in your rectum, there's a chance it could be pushing on that nerve and causing some of that tingling. All I knew is that once I had that bowel movement, it went away. So Vicki says I would go to the ER. I would at least urgent care if you have it. I think that this is a deep concern. Okay, Jeannie? I support what Vicki said. If you maybe call the ER, tell them that you're peeing blood, tell them that you're passing large blood clots, ask them if they want you to come in. Okay, but I would not wait a couple of weeks. I think that would be a bad idea. Sierra says, does our shop have coffee for ICers? It absolutely does. We have Tyler's no acid coffee. We have Bella Rosa coffee. We've got Simpatico coffee, and we have Dandy Blend herbal coffee. And the Dandy Blend herbal coffee is my personal favorite now. I think of all of the thing about coffee, this is not just the caffeine, it's the acid level. And there's one specific acid called chlorogenic acid that is what makes coffee so irritating to the stomach and to the bladder. And so chlorogenic acid is produced when coffee is roasted in these big metal bins, or something about the coffee bean touching that super, super hot bin that causes it. And so the Bella Rosa coffee has the lowest chlorogenic acid levels in the industry. And so I tend to put Bella Rosa coffee first. Prasid says, I think I need a pelvic floor assessment. My urine volume ranges from 400 to 800, but I have a urethral burning and burning after urination, but no infection. I really don't know what. Well, hun, your volume's really good. Your volume's really good. The fact that you have urethral burning points to potentially estrogen atrophy, and the fact that you have burning after urination, I would want to know, where is that burning after urination? Is it burning on your skin, or is the burning in your urethra? So is the burning after urination on your skin on the outside, or is it deeper inside your body? Proceed, tell me that, okay? Lisa says, is cystitis cystica similar to Hunner's lesions? What are your thoughts on cystitis cystica? Man, you know what? I read up on that years ago. Let me refresh my memory here. Hold on a sec. I don't want to. I do not want to. Oh. So cystitis cystic, they don't show that it normally progresses to something like bladder cancer. They say remarkably few reports document progression of cystitis cystica to carcinoma of the bladder, which is a good thing. And it looks like, where they're really focusing on just an inflammatory disorder, that the bladder wall has become extremely inflamed. So is that Hunner's lesion? Well, a Hunner's lesion is known for having a very red center. There's an area of profound, deep inflammation, and then it spreads kind of in arms around the lesion. I don't think cystitis cystica presents that way. Let me look at some pictures. Yeah, it doesn't. But it's inflammation nonetheless. It's, oh, wow, look at this. God, here's a really good picture. Wow. Wow, they've got some good pictures since the last time I read up on this. So I don't have any direct treatment information on this with respect to how it compares with IC. I mean, I think clearly in both cases, the bladder wall is compromised. If you're IC subtype 2 bladder wall driven, then your job is to protect your bladder. I think with cystitis cystica, your job exactly is the same, to protect your bladder and to reduce any and all potential irritants like coffees and sodas. I wonder if this could happen as a result of chemotherapy or radiation. And of course, we also have to ponder the role of infection, if there's any chance that you could have a chronic infection. I think if they find the big benign cysts in your bladder, next generation DNA urine testing would be revealing. Obviously, biopsies would be revealing to just try to understand what it is. I wish I could print this out. Did I turn off? You know what? My power bill is $600 a month right now. Can you believe it? $600 a month. Because I'm caring for 2 elderly people. And I turn everything off, and I'm trying to get it down to 200. So I have to turn everything off. Let me Let me see if I can print this out and show it to you because it's actually cool. Let me see if I can grab a quick picture of this. Okay, hold on. Let me open this. Okay, yes, I know an update is available. Let's do this. Let's do this. Ooh, look at that. What a good picture this is. Let me see if I can print this out. Do I have the right wireless? Gotta switch it on to a different wireless. All right. Okay. Yeah, 600. Well, you know, so I normally work in front of 2 computers, which I left on 24 hours a day because I was working all the time. And then a third computer, and then a computer downstairs. Yeah, we would have on average 5 computers on at any given moment, along with 3 routers. And my father would put the thermostat to 75 on cold winter days. And I pay all the utilities. So, okay, so anyway, proceed. Where is your burning? Is it on the inside or the outside of your body? Heather says, does anybody get severe leg cramps with IC? Absolutely possible. If you have IC that's being driven by tight pelvic floor muscles, your leg muscles go right up into your pelvic cavity. And so it's very common to have tight legs, tight thighs. Very common, tight hamstrings. More thighs than hamstrings, but it can be both. Shannon says, do you know a video I could watch to show me exactly how to do an installation on myself? I live far from my doctor and he showed me twice, but this is the first time I'm doing it. Honey, I don't. You're going to have to check YouTube, but I don't know if they would actually allow a video like that on YouTube. You might be able to find one on a medical website or on a nursing site, but I don't have one for you. Joni says, how do you diagnose pudendal nerve entrapment? I have 6 tingling toes that the doctor checked with a nerve conduction test and determined it was from my spinal stenosis from L3 to L5. I'm seeing a pain doctor for spinal stenosis and getting posture therapy and swimming and trying everything. How can a diagnosis be made so that the treatment I get is aimed at the right body part? Generally, they make the diagnosis with a nerve block. So if they suspect that it's your pudendal nerve, they can then use a nerve block and numb that nerve. And if that makes all your symptoms go away, that's your diagnosis. So the proper diagnosis is really just with a nerve block. Once you have all the symptoms where they would suspect that. Tabitha says, I'm not a coffee drinker. I tried Dandy Blend with unflavored coconut milk, frozen banana, and caramel creamer. It's a good sweet. Tabitha, that's my drink. I'm drinking that half of the time, except I don't put the caramel in. But the Dandy Blend with unflavored coconut milk, frozen banana, and you know what I'll do is I have a little vanilla sweetened coconut milk, and I might put a tablespoon of that in there. I don't like it too sweet. Dandy Blend, let's see. I can go get a copy, let me just go get the Dandy Blend. Do I even have it up there? Hold on. All righty. Dandy Blend. This is my next one. This is incredible. I mean, I just think it's just completely changed our options. And the cool thing too is it's 5 calories. There's no sweeteners in it. It's naturally sweet because it has dandelion in it. Love it. And you can get this right in the IC Network store. We have big bags, but we also have the individual bags. You can buy a box with 25 little individual bags, carry them in your purse. You can just open it up, pour it in a thing of hot water, and you're good to go. Kayleen says, hi, Jill and everyone. I was thinking about slowing down my monthly bladder instills. I've been cheating by drinking carbonated drinks. Ooh. Kayleen, come on. Don't do it. Just get some, get a carbonated like LaCroix. But don't you dare be drinking Cokes or anything like that. If you're going to have a carbonated drink, maybe at least do an old-fashioned root beer. But come on, you're doing so well. I don't want you to hurt yourself anymore. I have a post-op appointment with my primary next week and an installation on the 11th. I do have seldom pelvic pain and very tight pelvic floor muscles. You don't know what to do, honey. You have very tight pelvic floor muscles. There's this old adage: if it walks like a duck and talks like a duck, it's a duck. If your muscles are tight and you can't pee easily, then it's time to really get into and start working with those muscles. You're just recovering from your surgery. So we have to wait until you recover from the surgery. All right, you guys on YouTube, you're being a wee bit quiet. Just a wee bit quiet, if you ask me. Only Fanta and root beer. I don't know what Fanta is. Isn't Fanta a brand name? Or is that orange soda? Oh. Eek. Well, all right, Kayleen. Come on, girl. Confess. Which one? Which one? It looks like there's a lot of flavors. Okay. Okay, hold on. I'm just going to grab one randomly. So I'm going to grab the Fanta Peach, okay? Let me just look at it real quick. Nutrition facts. Carbonated water, high fructose corn syrup, natural flavors, citric acid, yellow 6, red 40, and sodium benzoate. Oh, you're doing pineapple. Oh my goodness gracious. Let us take a look. I know we all want the fruity flavor. Okay. Kayleen, I say this with love because I care about you. If you had an open wound on your hand, would you put carbonated water, high fructose corn syrup, citric acid, modified food starch, potassium sorbate, sodium citrate, medium chain triglycerides, salt, sucrose acetate isobutyrate, yellow 5, and yellow 6? Would you actually put that on an open wound on your hand? No, you wouldn't. Come on, girl. Do the root beer. You got to let that go. Trust me. Trust me. You've come so far. You got to stick to this diet for 6 months and really give everything the opportunity to calm down. You got to throw that out. You can't do that anymore. I say that with love. It's not just the caffeine, it's the acid level. Hun, I mean, listen, you know that you are not the only person who does this. I have done this many, many times myself. And there are moments when you just need something special, and you just need a treat. And so if you need a reward for doing something hard, and God knows you've already done something really, really hard because you just had all that surgery, then I'm okay with you rewarding yourself after going to the doctor once. One reward per doctor visit. And if you're going to choose that as your reward, you need to do it on ice with a lot of water and preferably some pre-leaf to try to reduce the acid load, because that pineapple Fanta, girl, that's pretty provocative. Hello, Jim J. And Sandy says, how long can you take muscle relaxers? It's a really good question. You know, I was doing some research on that not too long ago, just like literally last week or the week before. And I have been using Flexeril off and on for years for my mini tight muscles here and there. And I was really shocked that there was like a 3-month window. And so depending upon the muscle relaxer you use and how frequent you're using it, then you might want to reconsider. Now, I don't take it every night, but I do take it fairly regularly. I mean, at least a couple of times a week. I don't have any trouble stopping it either, though. So go to drugs.com, rxlist.com, and take a look at it, okay? And if you want, I can try to pull up the research that well, actually, I think it's right here. You know, here I am thinking, because I'm having moments when I walk into rooms and I forget why I walked into that room. Like, that's been happening a little bit more frequently the last 10 days, and it's kind of freaking me out. It's like going through menopause all over again. I'm just thinking hormone swing. But then I remember a lot of stuff. So anyway, let me just see if I can find that for you really quick. Was that in this one? Or was it in, you know what? I don't think it's in these guidelines. I think it's in, let me just look real quick. Interestingly, kind of on the same topic, AUA has made it crystal clear that they do not want you to be using azo or pyridium long term, not meant to be used for the long term. Anyway, go to drugs.com, rxlist.com, and check it out, okay? Tabitha says, does root beer have less carbonation? Not necessarily less carbonation, but it's usually caffeine free, and it's just, of all of the sodas, the gentlest one that most patients can tolerate. And again, I always recommend you have it on ice. You do a lot of ice, because as the ice melts, it will dilute it. And again, using pre-leaf, etc. Kayleen says, I can't quit cold turkey, but I promise I'll slow down. I keep 100-foot distance from tomatoes. Power to you, girl. So if you're trying to reduce, then let's just say you have one a day. So you can have one a day today and tomorrow. And then I go down to, let's just say one a day is 2 cups out of a can. I'm not sure if it is. So for the 2 days after that, go to 1 3/4 cups or 1.5 cups, and just slowly work your way down in volume until you're down to the 1/4 cup a day, which will help kind of keep, you know, part of this off, right? So just slowly wean your way off. It's okay. And the cool thing is it's non-caffeinated, and so you're not going to have that caffeine headache from it, right? Oh, Donna says, don't forget the printer. Oh, wait a second here. I got a printer error. Paused. Why is it paused? Okay, hold on. Bills. What is this? Okay. Okay, let me just throw these in the trash, except for this one bill right here that needs to be paid. All right, let me see if I can get this printed. File, print. No. Yep, yeah, it's working. All right. Let me get my... You know, cystitis cystica. This is a picture of cystitis cystica. This is interesting. So let's look at a couple of different findings, couple of different pictures. So this, for example, are pictures of Hunner's lesions. So I want you to look at this one, which you can see has a center red area, and then it kind of has lines radiating from it, right? So this is how a Hunner's lesion presents. This one right here, this is a really good one, right? You can see that up close. And so therapeutically, remember in the new AUA guidelines, if you're over the age of 50 and the doctor just suspects that you could have Hunner's lesions, let's say you've got blood in your urine and or your symptoms are really, really extreme, then they want you to have a hydrodistension or cystoscopy immediately to look for Hunner's lesions, because when we treat Hunner's lesions correctly, the pain goes away. Like 90% of the patients, we want to, if these are discovered or suspected, we want to get these treated immediately. They don't want you to wait. No more waiting 3 to 6 months. If they think you have lesions, let's get in there. Let's treat it to reduce your suffering. All right. Now, the second picture I want to show you, this is literally, I think, one of the coolest pictures I've ever had. This is a bladder stone. So this is hard. And it has rough edges. You can see the rough edges. So a bladder stone is basically a mineralization process that grows out of the bladder wall. And so in this case, this is a gentleman that I've known for many, many years. He's a dear friend, multiple surgeries. He's a surgical malpractice patient where he's badly damaged by a doctor. And anyway, these grew in the area. His bladder filled up with blood clots and it split in two. And they had to sew his bladder back together. And again, this is not IC. This was a very different type of bladder wall injury. And all along the incision, stones grew out. And that's because a severe injury like that interferes with some sort of calcium processing mechanism, right? And so these are so big, they cannot pass through the urethra, or they would get stuck in the urethra. So this is an example of a hard, rough edge mass. And of course, the other thing we know about bladder stones, kidney stones, is that they are often covered with bacteria. So imagine if this were floating in your bladder, it would be scratching your bladder. Think about it, floating in your bladder. And so as you pee, your urine level goes down. This basically can float right down the side of the bladder and scratch the bladder wall. As it fills up, it's going to go right back. So wherever this is touching, it has the potential of really irritating you down there. And that's why we want to make sure, you know, if your symptoms are persisting, there comes a point in time when you absolutely want somebody to look, because if you got bladder stones, they can treat those. They can break them up and get rid of them, right? Now, this is not as clear of a picture, is an image of cystitis cystica. So rather than it being hard, it's a soft, swollen piece of tissue, and perhaps a tissue that has, you know, it actually kind of looks like oh, what do you call it? Oh, the word will come to me. I had one in my uterus. Kayleen, you had one. What was the thing in your? Sorry, this is where my brain is right now. I'm just going through another age-related thing. Oh, come on, it's on the tip of my tongue. What do you call the thing that looks like a tongue? That's in your that. Oh, come on, Jill. This is so frustrating. Well, anyway, this is an example of kind of up. Thank you, a polyp. I think that, I just got to be real honest here. My stress level is over the top. I think that's why my hair is getting a little bit white right now. No, it's not a fibroid. It's a polyp. It's a soft tissue that actually kind of grows out. And the one that I had in my uterus when I had my hysterectomy was quite large. It looked like a tongue. It's crazy, right? Okay, so that's an example of cystitis cystica. Interesting. But it's benign. I mean, there's no sign of cancer in that. It's just funky. Could it be infectious? Possibly. They definitely want to rule that out. A polyp. I'm doing lots of deep breathing. I've been trying to do lots of deep breathing. I think we all have, we're kind of at that point where our bodies are just exhausted by stress, right? Presidium said the pain and burning is around the urethra, the vaginal base, and the perineum. When I sit with urine, there is a sharp pain from the base of the vagina up to the perineum. So we have to go to the EAU guidelines here, and let me read these to you. So if you remember, I use the Chris Payne subtyping system, 5 core subtypes, right? Hunner's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, central sensitization. UCLA, a couple months ago, they came up with 3 subtypes. They came up with bladder centric, which is Hunner's lesions, bladder wall driven. They came up with pelvic floor, and they came up with a subtype that was, again, these patients had frequency, urgency, pressure, pain, but they also had pain at the vaginal introitus and or the perineum. And so, and what UCLA found is for patients who had that pain at the vaginal introitus, the entrance to the vagina, that they did not respond to bladder therapies because they believed that the pain was coming probably from muscles and nerves. And the same is true with the European guidelines. The European guidelines basically say that if you've got pain, if you just have bladder-centric pain, then we would call you primary bladder pain syndrome. But if you've got bladder-centric and or perineum pain and or vaginal pain or rectal pain, you're not going to be given a specific diagnosis. You're going to be told that you have chronic pelvic pain syndrome. And in the European system, they talk specifically about this. And non-urological pain syndromes, and they call it primary vulvar pain syndrome. PVPS refers to pain in the vagina or female external genital organs that persist for 3 or more months and can be generalized or focal, in other words, broad or narrow in one location. The terms vulvodynia and chronic vaginal pain are no longer recommended. In general, PVPS patients, pain occurs in different areas of the vulva at different times and may be constant or intermittent. Touch or pressure does not initiate it, but can exacerbate it. In focal PVPS, the pain is at the vaginal introitus and is described as a burning sensation that only develops after touch or pressure, such as during penetration. So I would proceed. I would be asking number 1, is skin quality playing a role here? Do you have estrogen atrophy? And if you have estrogen atrophy, That's going to be affecting your bladder. That's going to be affecting your urethra. That's going to be affecting your vagina. That's going to be affecting your vulva. But if you're younger and you're not showing signs of estrogen atrophy, then you kind of fall into this chronic pelvic pain category. And our approach here is going to be really neuromuscular. We want to work on nerves and we want to work on muscles. And again, the UCLA study supported that. The UCLA study said, hey, these patients don't respond to bladder therapies. They need, and they're actually a bit of a challenging group. Also, the EAU guidelines talk specifically about pain after hysterectomy, that the incidence of chronic post-surgical pain after hysterectomy is difficult to determine. Rates approximate 28%, so careful case selection and management is important. There is also a significant incidence of pain at 12 months after C-section, so careful counseling is needed. And then they talk about mesh implants and how mesh implants can also lead somebody into a chronic pain condition. Rebecca says, I keep getting UTIs. I think it's an IC flare. I think more hormones are causing it. Here, hold on. So, Rebecca, you keep getting UTIs. Are they culturing out positive every time? Are they positive or negative? And if they're positive, what is the bacteria? And it's really hot. Let me, I need to get my hair off my neck. Hold on. Be right back. All righty then. Proceed says, yes, absolutely. All right, cool. Okay. Are we good? Are we good? Okay, so Rebecca, back to you, hon. You say you keep getting UTIs, and if you are, I want to know what they're culturing out as. Is it the same thing, or is it something different each time? So you have too much of the good bacteria. You have vaginal. Yeah. Okay, I got it. Bacterial vaginosis is no joy. Well, so are they saying that you're getting the same bacteria that's in your vagina in your bladder too? I mean, because you said you keep getting UTIs, and that's what we have to figure out. You remember the bladder only knows one language: frequency, urgency, pressure, pain. You could have a bullet wound or a stab wound and it would feel like IC. The bladder only has one way to tell you that there's a problem, and that is through the symptoms of frequency, urgency, pressure, pain. And yes, it feels like a UTI. We always think it's UTI, but in many cases, it's not UTI. It's injury or trauma or estrogen atrophy, right? They say it's too much good bacteria in your bladder. Renee says she has IC with ulcerations in your bladder. So Renee, in the brand new guidelines for IC that just came out, you're supposed to have those ulcers treated very, very quickly. That when you treat lesions, the pain goes away dramatically. Like in 90% of the people who get their lesions treated, their condition is stellar. And this is it's an absolute recommendation by the AUA. They only make 2 recommendations for IC care in the entire IC guidelines. The first one is if they think you have ulcers, they want you to have a cystoscopy and or hydrodistension with cystoscopy and get those ulcers treated. And then secondly, their other recommendation, absolute recommendation, is pelvic floor physical therapy. Rebecca, you have estrogen atrophy. Okay, but Rebecca, just bear with me here, honey, and I'm asking with this with the absolute best of intentions. You said you keep getting UTIs. You keep thinking it's an IC flare, and you think your hormones are causing it. Your hormones being off. Well, listen, if you have estrogen atrophy, it's much easier to get infected, because estrogen helps your body produce that nice thick coating of mucus. Think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste. And it's really kind of an evolutionary marvel. How can the bladder hold ammonia for hours at a time and not get damaged? Well, it turns out your bladder is like your mouth. It's a hollow organ covered with a really thick coating of mucus. We call it the mighty mucus. And the purpose of that mucus is to protect your tissue. And so it makes it difficult for any irritants in your urine to reach your skin, and it makes it difficult for bacteria to penetrate that mucus to infect cells. So mucus is important. Unfortunately, mucus is also estrogen dependent. So when you're young and you have lots of estrogen, excuse me, when you're young and you have lots of estrogen, you have lots of mucus, and you can get away with stuff. But once you're of a certain fine age, we are aging quite finely these days, you don't have the estrogen, which means you don't have that thick layer of mucus anymore. Thus, it's much easier to really get infected because you've lost an essential protective coating. So an estrogen atrophy patient has 2 things they've got to think about. Number one, it's easier for food to irritate the hell out of their bladder because they don't have that protective coating. And number 2, there's a big group of you who really do get recurring infection. The treatment for both is the same in the sense that we want to try to improve your bladder's ability to defend itself and your vagina's ability to defend itself. And the way that we do that is with topical estrogen. That when you give that skin estrogen, it immediately plumps up and starts producing mucus. So it's not that the lack of progesterone that's the problem here. It's understanding that you're actually doing the right thing for estrogen atrophy, which is giving that skin estrogen. What the progesterone does is it helps limit the growth of your endometrium so that it doesn't get too thick, because once you're of a certain age, you don't have periods anymore. And so that endometrium, that endometrial tissue in your uterus can get thicker and thicker and thicker, and that's not so good. If it's the wrong type of cells, then, that's considered a cancer risk. So normally if they give you oral estrogen, they give you progesterone. But there's a lot of compounding going on with creams. I mean, we've got Amibach creams, which are amitriptyline, baclofen, sometimes steroids, sometimes estrogen, sometimes lidocaine. Doctors tend to have their own preference. And so some doctors are prescribing estrogen testosterone creams. It's quite interesting what's going on. Tammy on YouTube says, I was diagnosed with a UTI 2 weeks ago. I was on Cipro, 500 milligrams twice a day for 7 days. Now I'm in a bad flare for a week with no relief. Why did they give you Cipro? Cipro is not supposed to be used anymore unless it's a complex infection. Cipro is associated with really significant adverse events, and the FDA warning on Cipro said that the risks outweigh the benefits. So I would want to know, Tammy, number one, did they culture the bacteria and identify it? Is it E. coli? Is it staph? Is it strep? Is it enterococcus? Whatever. And then number two, they would do some antibiotic sensitivity testing to try to figure out, okay, so you had E. coli in the culture. And so did they do antibiotic sensitivity testing? And that's why they gave you the Cipro? They're really clear. Cipro is not supposed to be used for simple UTI anymore. I'm really sorry that you're having a bad IC flare. So it could be that this, so it was our own National Institutes of Health who made a rather remarkable discovery in their IC research that some patients who are flaring because they have an overgrowth of Candida in their bladder. So why do we get Candida, which is a fungus, right? It's because of the use of antibiotics or consuming too many sweets. So one thing we could potentially say, Tammy, is that there's a chance that the Cipro killed all the good bacteria, which normally kept the Candida in check, and now you might have a Candida infection in your bladder. And if you come on over to the IC Network, icnetwork.org, and go into into our blog area, you can find the article which gives the reference for the studies which have found Candida. UCLA just confirmed that again a couple of months ago. They also found a very virulent, aggressive Candida in the bladders of some patients with bladder pain. So they didn't do any testing, so they just guessed, right? So they guessed like it was 30 or 40 years ago. Well, so this is a learning opportunity for all of us. If anybody suspects infection, they want to do a culture, try to identify it. And then the next step, the most important step, is to then test it to make sure you're giving it the right antibiotic. Because there's so much drug resistancy now that the last thing we want to do is give you an antibiotic that would just be a complete waste of time and damage your biome at the same time. So I think that there's also a chance, Tammy, that the Cipro didn't actually kill it. And now you might have a much more aggressive one. I would be on the phone with your doctor tomorrow. I would demand a new urine test and see if they can send a referral over to a lab so you can go pee in a cup, and let's let them test your urine. Or you can go to Walgreens or CVS and get UTI test strips. You can do that today and do a dipstick test, and let's see if you have signs of that infection continuing. I have samples here. Now, and you're certainly not gonna wait. Don't buy it from the IC Network, for God's sake. It'll take 5 days to get there. You need this today. We need to figure out why you're in so much pain. So a dipstick test will generally have 2 pads on it. Okay, and so if I'm going to take this out, you can just, hopefully you can see that there are 2 pads on it. I got 2 different cameras I've got to work with here. We turn it to the side. You've got a lower pad and an upper pad. You pee on the stick, sit it on your counter for a few minutes. Just follow the instructions. It's 1 minute for nitrites, 2 minutes for leukocytes. So the top one, and again, you can't really see it when I hold it like that. If I hold it like that, I think you can see it more. The top one is for leukocytes. The second one is for nitrites. Leukocytes are white blood cells, and so it would be completely normal, even if you were having a flare without infection, for this to turn purple, various shades of purple. But if the second one, if the nitrites turn pink, that's a very clear sign that you have infection, and you need to take a picture of this on your cell phone, send it to your doctor. Say, I don't think the Cipro killed this, and let's get them to do some better testing. Tammy asked, what antibiotic should I take? Honey, there's no way I would know that. They have to test the bacteria. There's no way we can tell what you might be resistant to. This is why this test is so incredibly important. I mean, it might be penicillin, it might be Reflex, who knows? So do this, go down to Walgreens and get one of their UTI test strips or CVS and test your urine, and let's see what you got. And if you got a double positive, then you still have UTI. You need to get to your doctor tomorrow and let them know you have a double positive, you're in agony. They need to get that urine testing done correctly, not just to identify the bacteria, but to identify the correct antibiotic. And then there comes a point in time where sometimes you have to go to the next level and do a much more thorough test called the next generation DNA urine test, which will really identify everything in your urine, good bacteria, bad bacteria, and fungus. Donna says, would probiotics work to correct this situation? No, we don't know. If there is active infection, we have to treat the active infection because we don't want it to go up the ureters and go into the kidneys where it can become a kidney infection and potentially a life-threatening infection. Tammy says, I was on Macrobid first. That's when they switched it to Cipro. Okay, well, honey, the proof is in your symptoms. If you're in terrible pain and it's the same pain, it may be that the Cipro isn't working either, right? It sucks these days when you have to deal with this. A lot of infections are getting much more difficult to treat. Tammy says, wow, Jill, just hearing you talk about vulvar pain really hit home for me. Diagnosed with IC, vulvodynia, IBS. Endo, my worst symptom has always been vaginal burning. Going on an antidepressant has helped tremendously. It's calmed my nerves down almost immediately. Yeah, so Tammy, that's you are in the IC subtype 5 chronic overlapping pain conditions, or basically in the chronic pelvic pain group. And thus your therapies are going to be designed at calming nerves down, along with potentially calming tight muscles down, that we're really not thinking that you've got a bladder disease and a bowel disease and a vulvar disease. We're looking at the commonality between them, which is muscles and nerves. And that's exactly why we now are calling IC a chronic pelvic pain syndrome rather than a bladder disease, because so many of us have symptoms outside of their bladder. Antidepressants absolutely are a great way to try to calm nerves down, as long as you can tolerate the side effects. If you're good with the side effects, power to you. Both the European guidelines and the American AUA guidelines talk about amitriptyline. Amitriptyline is remarkably good at calming nerves down, and the optimum dose, I think, is anywhere from 25 to 100 milligrams. They generally say that higher quantities are better, but they also say higher quantities are associated with a lot of side effects, and a lot of patients cannot tolerate those side effects, right? And so some of us can do antidepressants, some can't. If you can do them, power to you. I could not do them. Jim says, is there a good coffee supplement if you have Hunner's lesions? Yeah, absolutely. Dandy Blend. If you've got Hunner's lesions, you've got big open wounds in your bladder, any coffee is out, even low acid coffee. But this should be fine. Dandy Blend should be fine, even for patients with Hunner's lesions. There's, let's see. Let me just give you the blurb on this. Caffeine, 100% caffeine free with no acidity and no bitterness. No additives or preservatives, nothing artificial. There's no pesticides. Made of water-soluble extracts from 2 roasted roots and 2 roasted grains, nothing else. It's dissolvable in any liquid at any temperature. There's no steeping or brewing necessary. Sweetness comes from fructose that occurs naturally in roasted dandelion and chicory. And it's rich, smooth, full-bodied with no caffeine, acidity, or bitterness. I swear by this 100%. This is my cup of it right here. Look, you can see it. You can see it. I love this stuff. Love this stuff. And it's got some good recipes on it. You can make ice cream with it. You can blend it with cacao, chocolate powder. You can make an iced protein caramel latte, which is what I do a lot of. You can make marinades with it. Well, that's a good idea. Pancakes with it. Right on the IC Network website. And guys, it's really helpful. You know, when I show you products, I really hope that I know that you're going to shop around and you're going to go on Amazon and stuff like that. A lot of the products we sell cheaper than Amazon, especially all the natural approach nutrition products. But understand that when you buy from the IC Network, you're helping me do these meetings. And so I would really appreciate it if you could think about getting some things from us too, okay? Tammy said, I tried antidepressants in the past, no relief. Well, some people, remember, it's all about your subtype, hon. It's all about your underlying anatomy here. We have to understand the physiology of what's happening here. So if, for example, you are an estrogen atrophy patient, then all the amitriptyline is going to do is maybe quiet some of the irritated nerves, but it's certainly not going to fix the estrogen atrophy. What's going to help improve the quality and health of your skin is going to be estrogen. So we're getting much more specific now about really kind of looking at your body, understanding your body, and focusing on the right treatments for your body as compared to making you fit a universal treatment for everyone. The AUA guidelines are crystal clear. A one treatment fits all approach does not work. It does not work. Why? Jim says you buy from the ICN store a lot. Jelly supplements. Oh, thank you, Jim. Thank you very much. We do have low acid jams and jellies from Colorado Mountain Jams and Jellies. And that's a great company in Colorado, small family farm that make really good apple pie jelly, pear jelly, peach jelly. Anyway, you can come on into the IC Network and take a look at them and see what you think. And of course, you know, we have our line of supplements, the Natural Approach Nutrition supplements. The blessing that we have is that today in 2022, we have a lot of options for patients to try as compared to when I was first diagnosed 30 years ago, where we had nothing. I mean, we didn't even have Elmeron back then. All we had was antidepressants, and they didn't work for me, right? They didn't work for me at all. Today, now that we're focusing on underlying anatomy, and now we're trying to understand that in some patients it's muscular, in some patients it's neurological, in some patients it's chemical injury of the bladder or estrogen atrophy. And now we have supplements that can target those. And the American Urology Association, in their guidelines, they want you to try supplements because the supplements do not come with the risk of side effects that the 4 oral medications do. So before you ponder Elmeron, which we now know can be associated with retinal disease, or if you struggle with antidepressants because they made you gain weight or they make your heart race, they were originally in step 2 of the AUA guidelines, and they had supplements in step 1, and they want you to try the supplements because they carry much less risk. It's all about reducing the risk of adverse event. And so it's not me just saying, hey, think about the supplements. It's actually in our guidelines, and it's been in our guidelines for 11 years, 12 years now. We have way too much anecdotal evidence from clinicians around the country supporting that supplements work. Bladder Builder right now is getting rave reviews. Prevent is getting rave reviews from clinicians across the country. And if you were to go to the a variety of the professional classes that are taught on IC, supplements are in every class that are taught. There's a slide dedicated to supplements before they get to the stuff. And we know these supplements. We know Pre-Leaf is known for reducing acid in food. So the oldest and most well-known supplement is Pre-Leaf by far. Really good news from Pre-Leaf. They are now bringing back permanently their granular powder. I just had a meeting with them last week, and we're doing some really fun things. So Pre-Leaf is here to stay. They're really, it was sold from one company to AK Pharma to GSC Healthcare Solutions, and we always want to make sure that these companies take IC seriously because this is important. It helps many of you eat. And so if you're not familiar with Pre-Leaf, this is Pre-Leaf. And we will have some new packaging too. But so if you do have to go somewhere and you're going to be exposed to something acidic, you can bring some Pre-Leaf in your purse or in your pocket, and maybe that'll help reduce some of the irritation. And then, of course, we have Bladder Builder, which I think is the most dynamic and most effective supplement on the market because it can help you 4 different ways. It has chondroitin to coat the bladder. It's got quercetin in it as an antihistamine. It's got beneficial probiotics in it for the gut. But most importantly, what makes Bladder Builder, in my opinion, the best supplement on the market is it has a pain-fighting ingredient in it called PEA, palmitoyl ethanolamide. And we had research presented at AUA in 2019, which showed that this very simple over-the-counter supplement is very simple fatty acid, extremely well tolerated by the human body, no side effects reported in the IC study. By 3 months, 87% of patients using PEA and resveratrol showed a significant reduction in their pain, and by month 6, a significant percentage were pain-free, and that's what we're finding. So Bladder Builder is, and that's what this looks like right here, except this is an old bottle. It's not the newer bottle. Bladder Builder is the only supplement that has something to help protect the bladder wall, something to reduce histamine activity, and something to reduce pain. And we did a 1-year follow-up study with it last year. 60% of the patients who tried Bladder Builder love it. They report shorter flares, fewer flares, less painful flares, and some patients are pain-free using it. 40% of the patients who tried it didn't like it. They couldn't afford it, or their doctor wanted them to do something else, or they had a side effect. And usually any of the chondroitin-based supplements can cause a gut-related side effect. And so, if you flare when you have yogurt, then we would say don't do Bladder Builder because it's got probiotics in it. Some people flare from yogurt because of a histamine reaction. The next one that we would be looking at is Bladder Rest, which is a clean, pristine formula for people who are more sensitive. And then, of course, we've got Cystomend, which is a really strong chondroitin product, really good for patients transitioning off of Elmeron. And, of course, we've got the old standby, Cystoprotect, which has been around forever. So as the AUA says, we've got a lot of options, and we're all unique. And so if you don't like one, you can try another. And if you don't like any of them, fine, but at least they're available. And they certainly are helping some patients, not all of them, but some of them. And it certainly begins with your subtype. If your subtype is pelvic floor driven, I wouldn't want you to put your money into supplements. I would want you to put your money into pelvic floor physical therapy. Does that make sense? I hope that makes sense, kind of, sort of. Tammy says, how do you know if you have estrogen atrophy if your skin's dry? Are you dry? Is your vulva dry? Is sex more painful? Is physical therapy uncomfortable? That's how we know. Or do you have what we call urine burn, where as you're peeing, your skin feels like it's being burned by urine, and it's really not being burned. It just means your skin is dry and not able to protect itself from the irritants in urine. So, yeah, urine burn. That would be another clue. Tammy says, antibiotics always cause pain and burning for me. Yeah, antibiotics can. There are some antibiotics that are pretty harsh and aggressive. Others aren't so much. Keflex, for example, is not particularly bladder irritating for many, whereas Augmentin can be very bladder irritating for many. Renee said, my urologist did a cystoscope on me and he pierced your bladder. Yes, that's tragic. How the hell did he do that? Was that a hydrodistension with cystoscopy, or was it just a cysto in the office? Like, what the hell? That's crazy. I mean, I'd love to hear the explanation as to how that happened. Vicky says, I'd love to try cream, but I had breast cancer, so I don't think it's allowed. Actually, if you Google topical estrogen safety, look at the research. The research is actually saying, in fact, there's a paper in the last 6 months where they said that topical estrogen did not appear to increase the risk of cancer, including in current cancer patients who are estrogen dependent. Topical estrogen stays in the skin. It does not to any great degree get into the bloodstream where it can go to different parts of the body. But don't believe me. Do your own research. Google topical estrogen safety, and you read the research and see what you think and if you're comfortable with that or not. Some people would be comfortable with it. Others wouldn't be comfortable with it. Alita says, how can Candida be diagnosed? They can take a swab. Like if it's vaginal Candida, what they would do is they would take a swab, look at it under a microscope, and you can see the Candida. Candida is little round circles or little stems with circles on them. Or they can do a next generation urine test or next generation vaginal swab. And I think I take that back. That was for a virus. Anyway, those would be the two most common ways. And of course, if you have a discharge, they should certainly look at that discharge. I will tell you, I had a drug-resistant Candida labrata infection for 2 years. I never had a discharge with it, and that sucker hurt like hell. Let me tell you, Candida in your bladder is agonizing. And I got it from doing long-term antibiotics because back then we all thought IC was bacterial. Now we know it's not bacterial for a lot of us. Tammy says, should I try pelvic floor physical therapy? Well, Tammy, do you have tight muscles? If you have tight muscles, yes, you should try pelvic floor physical therapy. At a minimum, go have a pelvic floor assessment and let's see what's going on with your muscles, right? If you go to urinate and you can't release urine right away, you're sitting there 5, 10, 15, 20, 30 seconds, a minute, 2 minutes, 5 minutes before you can relax enough to release urine, then yeah, you have tight muscles. You know, they should, at their very first appointment, urologist at your very first appointment with you should be checking your pelvic floor. And it is an immediate referral to pelvic floor physical therapy. If they find you have tight muscles, the AUA says, and it's a strong recommendation, get that patient to pelvic floor physical therapy. It works beautifully. Anne says, this is my third go around for pelvic floor physical therapy. My insurance will cover it every year, so I'm going again. Good. Yeah, I mean, it's for those of us who have long-term chronic tension because we have what we call a bony structure abnormality, like a bad hip, a bad SI joint, bad knee, etc., then it's going to be something that we're going to be working on for a long time. My pelvic floor right now is good. My pelvic floor a week ago was not happy. My pelvic floor today feels really good. Tammy says, I was allergic to amitriptyline after day 24 on it. I started getting huge bruises and hives. I ended up on Zoloft and I'm tolerating it very well. Good. Good. Yeah, amitriptyline messed up my heart rhythm. So, we all have our own issues. Joni says, my hydrocystoscopy showed mast cells. What causes mast cells? Mast cells are a sign of inflammation. They're part of the inflammatory process. There's something called eosinophilic cystitis, too, where your bladder can be filled with a lot of eosinophils, which are white blood cells, which are sent to the area usually because of some sort of strong allergy. So all of our skin has mast cells. They're just part of our anatomy. The question is are the mast cells irritated and releasing histamine? It's the histamine that causes the itching, the irritation, the pain. When you get bit by a mosquito and it injects venom, that venom irritates the mast cells, which then releases histamine, which causes all the redness and the swelling. So it means you got triggered. They got triggered. Vicky says, I finally got diagnosed last summer and she immediately offered Elmeron. Ooh, powdered pre-leaf. Well, yeah, girl. It's the new AUA guidelines are crystal clear. They instruct urologists to talk to patients in depth about the risk of Elmeron and eye disease. They want you to, if you have any history of prior retinal disease, and it's pretty much off the table. If you have a risk for it, they want you to get a retinal exam before you begin so that you can look and see if your retinas are changing over time. And then if you are taking it, they want periodic eye exams so that you can keep looking at your retina to make sure nothing is changing. And I just found again, let me show this to you. So just to give you an idea here of what they look for. Okay, so this article was the first article that was written by the researchers at the Emory Eye Institute who believed that they had found a new retinal disease caused by the use of pentosan polysulfate, which is the scientific name for Elmeron. Elmeron is the brand name. And there are many, many more studies on this now. I mean, it's been confirmed or found at multiple centers by multiple ophthalmologists. So let's take a look at, so these are slides over time. So, and let's see, are these different, let's see. The top row is color fundus photographs demonstrating that nearly all eyes show subtle pigmented deposits, right? So you can see these areas where the color has changed. And then this is a different exam, and this is over time. So you can see this is at the first appointment. This is a later appointment. And over here, we can see, you can just see that it's changing over time, right? And there are very academic names for the tests that they do. The autofluorescence patterns within the diseased region was characterized by a network of hyperautofluorescent spots that corresponded to the vitelliform-like deposits noted on the fundoscopic examinations. But there's another picture here. Let me find this other picture. Okay, so there's actually two different types of pictures here. So this is kind of from the top down, right? So you can see the retinal deposits changing over time. But it's actually this bottom one, which is a cross section of the retina, which is really quite interesting, because you can see very clear changes in what should be a smooth retina. I mean, I'm not probably saying that the right way, but this is straight from the researchers. And of course, there are class action lawsuits going on right now in federal court and state court representing hundreds of patients. So it is a thing. It is a thing, and it's very, very sad. So again, Vicki, the AUA guidelines have a specific guideline statement. It's written into the guidelines that, let me just read it exactly. Guideline statement 15, clinicians should counsel patients who are considering pentose and polysulfate on the potential risk of macular damage and vision-related injuries. There have been recent reports of a unique retinal pigmentary maculopathy that is associated with pentose and polysulfate use. Symptoms have included difficulty reading, slow adjustment to low or reduced light environments, and blurred visions. The initial, okay, well, anyway, it is, okay. The initial evidence consisted of case reports and small case series, but subsequent large retrospective cohort studies confirm the association. The prevalence of maculopathy varies widely in pentosane users, but appears to be related to the cumulative amount of exposure. Given these concerns, the FDA approved a new warning label in June of 2020, which states that 1, a detailed ophthalmologic history should be obtained in all patients prior to starting pentose and polysulfate. Number 2, for patients with pre-existing ophthalmic conditions, a comprehensive baseline retinal examination is recommended prior to starting therapy. Number 3, in addition, a retinal examination is suggested for all patients within 6 months of initiating treatment and periodically while continuing treatment. If pigmentary changes in the retina develop, then risks and benefits of continuing treatment should be reevaluated, since these changes may be irreversible. That's not me saying that. That's the AUA guidelines saying that. Okay? I mean, woo! What a time we are living in. Vicki says, do they help you personally with your pelvic floor and hypersensitivity? I'm not understanding the context of that. Wow, Renee, who had her bladder pierced. The urologist did not tell you. You found out 3 days later when your abdomen filled up with blood, 4 days in the hospital. Holy hell, girl. You know, you always know. So if you're going to have, first of all, guys, hydrodistension with cystoscopy is not required for a diagnosis of IC anymore. It's only done if the diagnosis is in doubt or if the doctor strongly suspects that you have Hunner's lesions. And we now have new technology that will allow doctors to not do a hydrodistension. They can just do a cystoscopy in the office without any water. They use something called narrowband imaging that will allow them to study your bladder wall and identify lesions without you having to endure the risk of a hydrodistension, right? Because when you fill the bladder with water, if you fill it too much, you have a chance, which you're certainly going to stretch the bladder, which is going to be painful, but there's a chance that the bladder could rupture. And so the other thing to understand is that high pressure, long duration hydrodistensions are no longer recommended in the United States. That was what they used to do years ago, when the theory was, hey, stretch the bladder to increase bladder capacity. But if you ever came home from the hospital with a catheter and blood in your urine, but usually if you're sent home with a catheter, then something happened. Something happened that where you may have had a lesion which ruptured, or something traumatic happened to that tissue. And generally what they would do is send you home with a catheter for a week, give your bladder time to heal, and then they would take the catheter out. It always surprises me. I mean, it's not common, but I've certainly worked with a couple of patients over the year. They've had that happen, but nobody told them why they had a catheter. They didn't find out until much later. So, Renee, I'm really, really sorry that happened to you. And I think that if I were in your shoes, I would probably have a few questions. Like, number one, How did this happen? Was this a mistake? I mean, you were in the hospital for 4 days. And if somebody made a mistake, they need to tell you that mistake. Or did you have an area of your bladder so thin that it just ruptured with even a tiny amount? So I would really want to know what happened. Did they do a high pressure procedure as compared to a low pressure procedure? If they did, then, I mean, that hasn't been recommended since 2008? No, 2011. 11 years. I would certainly have some words for them. That's very unusual. Loretta says, my breast oncologist okayed me for low-dose vaginal Vagifem. Awesome. Jim says, how long will it take to see an improvement after stopping caffeine when you have Hunner's lesions? I think you would see a result fairly quickly. You remember, nothing happens overnight in the bladder. The bladder is the slowest healing organ in the body, so you're going to have to give it at least 2 weeks. It takes 2 weeks for one cell to be replaced. But what I would hope and expect to see very quickly is that you would start sleeping better, because you're no longer pouring active acid in the middle of this very tender, vulnerable lesion. So for some patients, losing the coffee is almost miraculous. I've shared this story of this patient that I worked with who was drinking a pot of coffee a day, followed by a 6-pack of Diet Coke, and she didn't believe anybody, including me and doctors, that was causing her pain. Spent tens of thousands of dollars on treatments that had no chance of helping her, because there's no treatment that can counteract the damage of pouring that amount of acid on a wound in your bladder. She was doing it to herself. She was sabotaging the chance for any of those therapies to work. And so once you stop pouring acid on those wounds and give that tissue time to actually repair itself, and that's not overnight, it's going to take weeks. And I mean, I usually tell patients that for those of you with Hunner's lesions, you're going to be on a modified diet until the lesions have resolved, right? I mean, no coffee, no soda, nothing like that, because you literally have a big giant wound in your bladder. And we need to get those wounds treated, which is what the AUA says. But for the patient with lesions, you've got to be the most diet motivated to really calm things down and heal things. So Dandy Blend, perfect option for you. So I'm going to expect somebody with Hunner's lesion is going to be on the diet indefinitely until the lesions are treated correctly. If you've got estrogen atrophy, bladder wall driven, chemotherapy, something like that, chemocystitis, then I think you're going to be on the diet for 6 months and really give all that tissue time to calm down. And let's see how you do. Hopefully you're doing avoiding diary. And then, once things start to feel better, that's when you start making a mistake. You start drinking all that coffee again. When it's time for you to try stuff again, you need to do our coffee challenge. We have a 6-step coffee challenge where start first with chamomile herbal tea or peppermint tea. See how you do with that. If you do okay with that, your next step is a rooibos herbal tea, which is a brown grain herbal tea. If you do okay with that, your next step is an herbal coffee like Dandy Blend or Pero or Cafe Ropa or Ticino. If you do okay with that, then you're ready for the big boys. You're ready for the real coffee, but it has to be low acid, preferably decaf. So I would be looking at the Bella Rosa coffee. And the cool thing about Bella Rosa is they make a full decaf, full calf, but they also do a half calf. And for those of you who you just have to have that little bit of caffeine for one reason or another, migraines or whatever, Bella Rosa does make a half calf, which can really fit that bill. But we really don't want you to go on anybody to be on full calf if you're struggling with frequency, urgency, pressure, pain, because it's like taking a jackhammer to the nerves, hon. It's going to hurt. It's going to trigger more frequency and more urgency. It's neurostimulatory. Tammy says, what test is done for antibiotic resistance? Is called an antibiotic sensitivity test. So basically, let's see. Let me see if I can do a diagram here. I don't know if you know what a Petri dish is. So a Petri dish is a round, flat dish, right? Oh, you know what? I need something darker. Let's see here. Do I have a marker in here? I do not. So it's basically a round, flat dish, and what they do is they drag some of your urine along the top of it, and then they wait 24 hours to see if any bacteria grow. A Petri dish is filled with a growth medium. It's food. It's bacteria food. So if there's any bacteria in your urine that is capable of eating that food, it will eat the food and start to grow. And so let me, I did this. This was my senior project at UC when I got my pharmacology degree. It was on the isolation of drug-resistant infections from public water fountains and bathrooms and sinks. All right, so that's the shape of a Petri dish, right? It's about this tall and it's clear plastic. And then there's kind of jello at the bottom of it, kind of gold, brownish, tannish jello. So what we would normally do, well, what I did for my senior project is I had the urine or whatever my sample was on a little stick, and I dragged it like this, right? So this was where I put the sample, right? And then I put it in an incubator. And when I came back, there would be, you know, little populations, little and big populations of bacteria. They could have been white, brown, black. It's really quite interesting what can grow. So 24 hours later, this is what they're going to look for. They're going to look for circular growths of bacteria, okay? Then the next step that they can do is we had little tiny round discs soaked, little pieces of paper soaked with different antibiotics. So we would isolate the bacteria, and then maybe what we might do is we might just try to grow a whole plate of it, right? So I'm taking that proven infection, and now I'm growing a new agar plate, and I'm going to try to get this whole thing covered with this bacteria. And then I'm going to put these round paper discs, okay? And each of these round paper discs were coated with an antibiotic. And then I wait another 24 hours and come back. And if the antibiotic worked, all the bacteria disappeared from that circle. If it didn't work, the bacteria continued to grow. So, you know, it's fascinating, fascinating, fascinating. Now this was 30 years ago, but this 40 years ago. That's the way they did it. Today, they don't necessarily make you wait 24 to 48 hours. Now they can just look at DNA. They can do a next generation DNA urine test. They take the urine, stick it into a machine. They use PCR testing, and they can look at all the DNA found in there and match it up to identify the bacteria that's in there by name. And then they compare that DNA with big databases to show what antibiotic resistances are present. So this method is the old method, but a lot of labs still do it this way. The new method, the cheaper and much more quicker method, is called next generation DNA urine testing. And I have a whole website on it, bladderhealth.org. Many believe that it is the absolute future of urine testing. Other people are resistant to change and they don't want to do it. All of the viral testing for COVID is next generation testing too. It's quite interesting. If you look at the COVID tracking, they're deliberately tracking all of the mutations, and the way they identify the mutation is through a next generation test. Anne says, me too, like you, you had no discharge with your Candida. Yeah, I thought it was fascinating. I never had. I think only once did I have a bloody discharge, and it was just a really, really bad yeast infection. So Vicky is asking if the supplements help with the pelvic floor or hypersensitivity. Indirectly. So remember that one of the reasons why your pelvic floor gets tight is a guarding response. If your bladder's screaming in pain, that message is sent to your spinal cord and to your central nervous system, which then immobilizes the area because they don't want you to move. It's called the guarding reflex. So your muscles will get tight in response to pain. And so if we can try to reduce that superficial bladder wall irritation, then your muscles might not be as prone to getting tight. So if you were an estrogen atrophy patient doing a chondroitin-based supplement, then that just makes sense that we're kind of treating the underlying problem that will hopefully then stop stimulating your muscles to be tight in that guarding response. The far more important question is, can any of the supplements calm nerves down? And the answer is yes. PEA, Peora, is the supplement. It's the only supplement out there which has a proven nerve calming effect, palmitoethanolamide. And this was the research that was presented in 2019 by the Europeans. And so this is the American variation of the European formula, Peora. And so a lot of people ask me, what do I take? This is what I take every night. I take 2 at night. And I am a central nervous system patient. I have very sensitive skin. I have a wicked sense of smell. I have all those hallmarks of central sensitization. And prior to using Peora, I used to, hold on, my shirt's getting all weird. I used to struggle falling asleep because I would get pinpricks in my skin. And I would always have lotion in my bed because it was like I had dry skin. So wherever I get a pinprick, I'd put lotion because I just thought it was dry skin. And there were moments when my skin was so sensitive, I literally had to take a little bit of Norco to go to sleep. The pain was crazy. And we call that small fiber polyneuropathy. For those of us who have a lot of skin sensitivity, that's usually why. And with this, it's gone. My skin is so much happier because I've calmed the nerves down. So you can look at the research for palmitoyl-ethanolamide. We have it on our website. I can show it to you here. Doctors were really excited when PEA was presented at the urology conference because they finally had something that could help with pain that wasn't an opiate that they didn't have to worry about all the opiate requirements and addiction and all that sort of stuff. So PEA is, in my opinion, a good alternative for somebody with nerve sensitization. There were no side effects in the IC study. I went through many studies, very, very well tolerated. I only found one study where there were very mild side effects, the rest extremely well tolerated. And so it's a viable option. I would learn more about it. Don't believe me, Google it, read about it. Michael says, which supplement is better? I've been taking Peora and have felt better, but is the Bladder Builder better? Well, the Peora is just really straight for calming nerves down. There's nothing in Peora for your bladder wall. But if you've got estrogen atrophy or your bladder wall is compromised in some way, like through chemocystitis, then Bladder Builder would help you with both, right? So the challenge is the Bladder Builder is anything new. Go slow, for goodness sake, like 1 capsule with food, wait 24 hours, see how you feel. 1 a day for a week, see how you feel, then 2 a day. You can slowly work your way up to the manufacturer recommended dose of 4. But a lot of people don't ever get that far. They're fine with one a day. And so it's about finding the dose that works for you. I am not, one of the concepts that I learned when I got my degree in pharmacology is the difference between lowest effective dose versus the highest effective dose. What's the lowest amount you can take and still get a beneficial effect as compared to what's the highest amount you can take? The more you take, the greater the risk of adverse event. And being a sensitive redhead, I already knew that. And so I'm a less is more kind of person. I don't believe in taking more of anything for me personally. I think it's, I look for the lowest effective dose for me personally. Tammy says, does I have burning after and not during urination? Would that rule out estrogen atrophy? No, that would kind of confirm it, hon, if it's on your skin. If you have urine burn on your skin, that points us to potentially estrogen atrophy on your skin, or it points us to your muscles. How do we tell the difference between bladder-centric versus non-bladder-centric? People who are bladder-centric, you take it, you have pain as your bladder fills with urine that is relieved by urination. So the fuller you get, the worse you feel. But once you peel, you feel better. That's telling us your bladder wall is involved. If you don't have that, if you have pain after you're done urinating, then your bladder is not the problem. It is something else, usually your pelvic floor. But again, we have this unique situation of urine burn, where as the urine is coming out of you, if it's burning your skin as it's coming out of you and your urine feels hot, that's estrogen atrophy. Woo, somebody just went to the bathroom. Woo, that's a stinker. Let me shut my door. Woo, actually, I'm going to do one of my very friendly room sprays. Here, guys, hold on a sec. I got to check on my mom. Are you okay? Oh, that's athlete's foot stuff. What do you call it? Low-German. That's it. That's it. Yes, that you spray it right on your foot. No, that's not it. This is. No, she's got it. It's the antifungal stuff. And that's a steroid. What do you call it? An antifungal. It's an antifungal.
Where are you using it?
She's got
Where on your body do you propose to use it?
her foot.
That's her answer.
That's what she told me. Her foot. It's on your feet, right? Yeah, it's on her feet. Okay. We can spray it during the day. I'm almost done with on my meeting. When I'm done, we can spray it too. Do you want me to put your hair up? Did you eat your breakfast? Okay. 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 Looks good. No, she has it.
Okay, don't do it.
I've already done it. It's between her toes. And the lady, we've been working on this for years, Dad. I just looked between her toes not a month ago. She has it. All right. It was a kerfuffle over athlete's foot medication. Michael says, can you And I'm sorry, I'm sorry if I'm not pronouncing your name correctly. I apologize if I'm not. Can you take Peora morning, night? Sure. Tammy says, what kind of urologist should I see to check out my pelvic floor? You would not see a urologist for your pelvic floor. You would see a pelvic floor physical therapist. You can go to your gynecologist and ask for the referral. You can go to your primary care doctor and ask for the referral. But a urologist and or a urogynecologist at your first appointment should check your pelvic floor. And if it's tight, it's an immediate referral to a pelvic floor physical therapist who will do a comprehensive pelvic floor examination where they actually touch muscles and try to figure out which muscle groups are the problem.
Stop it. Stop it. Stop it. Can't have a problem with stop it. J-O-C-K. Stop it.
You know, it's hard when you've got two elderly people who are hard of hearing and they start to have a conversation, they have to yell at each other. And so my dad is yelling, jock itch, jock itch. Oh, he's 99. He'll be 100 in November. What a life. What a life. Proceed says, my symptoms are quite similar to Tammy's, and I have pelvic floor tightness as well, which means I have to check my pelvic floor. Absolutely. Yes, absolutely. That's a thing. Pelvic floor, tight pelvic floor muscles have a consequence. Their consequence is that they restrict blood supply, and it's very hard for your bladder to be healthy if it does not have good blood supply. So we need good blood supply in there. That's our primary goal with somebody with pelvic floor tension. Donna says they are so funny. They are exhausting. All this white hair coming in. Yeah, this is COVID and senior care, elder care hair right here. I just it's the stress is real. It's just real. Alrighty. Well, guys, we've been doing this for 2 hours, so which is longer than I thought it would last, given the day today. So let's do a last call for questions. Last call for questions. Tammy says your parents are blessed to have you. Listen, I don't think I'd be here today if I hadn't had them when my IC started. Come on, I was 32 years old, but I had issues in my 20s with all the IBS and the vulvodynia and all that sort of stuff. And my parents are the single reason why I survived. Honestly, if they hadn't, I mean, here you have an adult daughter. Yes, I'd been to graduate school. Yes, I was successful in some areas, but I wasn't living a normal life. They knew that. I knew that. We all knew it. We didn't understand what was wrong with Jill. Now we know what was wrong with Jill, that it's a central nervous system issue combined with a muscle issue, that it was really never my bladder. But, it was my mother who drove me from South Lake Tahoe back home with me crying in the back seat of the car, writhing in pain during a flare, after she said she would never drive freeways again. It was my mother who drove me to UC San Francisco on the days that I could not drive to go have my ankle stimulation. It was my father who drove me to the emergency room several times because not only of my IC, but getting bitten by a black widow spider. And, I am very, very blessed that they were willing to help me for a long time, like literally from like 25 to the age of 40. until things got better. And thank God things got better, and I'm better now, and I'm perfectly capable of supporting them and paying for everything and all that sort of stuff. But I went through a good 10 years where I lived on credit cards, and little bit jobs here and there. And so it is my honor and privilege to do the same for them. It's hard doing it without any help. Like, I have not had a night away in over 4.5 years. And that's not healthy. But that's the pandemic. I can't bring, my dad's unvaccinated. And my mom is very vulnerable. I can't, in good faith, bring a nurse in to swap for me if that nurse is going to other houses. I tried a couple months ago, and I said, so how many homes do you go to? And it's like about 10 a week. And I'm like, you're vaccinated? Yeah, they were fully vaccinated. I said, and do you test at least once a week? And she said, no. And I'm like, then I can't have you come to my house. And my brother is completely unwilling to help. He refuses. He's living in his own separate world, for which I do not understand. And my sister is unable to help because she's been quite ill. So, all I can say to myself is, because I have these moments where I just go, why? Why? And it always comes back to, you're exactly where you're supposed to be. You're exactly where you're supposed to be right now. So that's my curming faith. Adidra says, I'm so sick of this illness. Adidra, but don't look at this as an illness anymore. Our new treatments, which actually is curing people. Dr. Payne wrote in his guidelines it's criminal to tell patients they have an incurable bladder disease when you may have a perfectly curable pelvic floor problem. Adidra said, I just want to drink liquids in peace. Adidra, honey, this is a bit of a reckoning in a way, because it does force us to accept the fact that today's modern day diet is so unhealthy. And so if you were a coffee drinker and a soda drinker, there comes a point in time where there is a reckoning, because our body was never designed for massive amounts of coffee and soda. Our bladder, the bladder we have today represents evolutionary adaptation from 5,000 years ago. There was no coffee 5,000 years ago in Norway, where I come from, Norway and Sweden. And so our challenge here is that our food producers are extremely manipulative, and they create a lot of artificial addiction to try to keep you buying their product. And that's why we see sugar in everything, and artificial sugars in so many things as well. Sugar triggers the same center of your brain that cocaine triggers. A sugar addiction is agonizing. A caffeine addiction is agonizing. They want you addicted so that you are a perpetual customer. Why do you think they created Happy Meals? They want to addict the children. They want the children hooked at an early age. And so there are some very good, I love documentaries. There are some very, very good documentaries that have talked about the toll that today's modern diet has taken on kids and on us, and the toll that it's taken over time. I mean, one of the documentaries was talking about what is good food, right? And what was fascinating about it is they went right back to mother's milk. You figure the most important food of all is mother's milk, and it turns out in mother's milk, there's no food for the human body. There's nothing in mother's milk that nourishes the human body. Mother's milk nourishes the good bacteria. So the purpose of mother's milk is to help that infant establish a good, healthy colony of beneficial bacteria in the gut. Right. So that was mind blowing. and then they went into kind of the amount of sugar that's in so many products that we're all exposed to, like in ketchup, uh, regular milk. When I was in school, we all had little pints of milk, and then all of a sudden it became chocolate milk. And it was the chocolate and the chocolate companies that went to the milk industry that said, hey, you want your kids to drink milk, they'll drink more milk if they drink our chocolate milk with sugar in it. And the milk companies went for it, and then the school districts bought it. And I remember in this one documentary, they wheeled out a wheelbarrow with all the sugar in it that a child is exposed to when they're in, I think it was when we're in school, and it was this giant wheelbarrow filled with a massive amount of sugar just from all the incidental exposures from all the sugar that's now being added into our diet. Adidra says, yes, I can't drink or eat dairy products anymore. I just started using, I got to tell you, I just started using coconut milk butter, and it's really good. I had to bring down saturated fats massively because my mom has atherosclerosis in her aorta. And so it's like no more saturated fat. So we used to use a lot of butter because hello, Norwegian. Now I only use butter if I'm making a little bit of white sauce. I use this coconut milk, a pot of butter, it's like, I can't believe it's not butter, but it's just made with coconut milk, and it's great. And also, too, by the way, right here, Proceed said, absolutely, our parents are treasures for us. I'm still being reminded of them where they are now up in heaven, and their spirit's always guiding me, like guardian. Oh, yeah. I feel my grandmother. I got to tell you, I had two kick-ass grandmas. The grandma, my dad's mom, is my lead guardian angel. She was a tough cookie. Man, she was a Navy wife before World War II. My dad was born in the Philippines on a Navy base. You want to hear an absolutely hysterical story? This is my grandma, and I look like her. I'm like almost a twin for her, except, yeah, I know, I'm almost a twin for her, which is amazing. So my grandfather, my dad's dad, was very dashing. He spoke 8 languages. He was from Europe. Very princely, for lack of a better term. Very, very dashing, very, very handsome. We have pictures of him. And so he met my grandmother when they both immigrated to the United States, fell instantly in love. He then went into the Navy, right? He was an officer in the Navy. So they were traveling the world. They were stationed in China, and then they were stationed in the Philippines. So she had the entire family. There were 6 kids, right? All in the Philippines, young kids. And he got malaria or something like that. And so he was sent to Hawaii. He was sent to a Navy base on Hawaii. She got on one of those passenger cruise liners with the family, followed him to Hawaii, right? Walks into his hotel room. His hospital room. There are 2 ladies there who have taken a liner from California to be with him. By golly. He, the women fell for him and he fell for them. So she walks in, kids in tow, to these 2 other women sitting in his bed, holding his hand, right? And she nails them, kicks him out of the room. One of them offered to buy him. I will give you however much money you demand if I can have your husband. And she said, no, get the hell out. He's my husband. That's my guardian angel. She's with me all the time. And there are so many stories like that. It's hysterical. So I believe in angels, and I absolutely believe that they're always with us, and they never leave. They never leave. They're always here. At least I feel them always. Not all the time, but as I'm contemplating my actions, I can hear Grandma 1 saying something and Grandma 2 saying the other thing. Oh. Okay, so the Clean 15 and the Dirty Dozen came out 2 weeks ago. We're talking about food. And the Clean 15 and the Dirty Dozen are food lists of the foods that are the most contaminated or the least contaminated with pesticides. And this is from our own government lab testing. So this is data straight from our own government testing. And let's see here. I just put a big article on that in our magazine, which is at the typesetter right now. Doing a big spring, summer, IC Optimistic double issue. It's just a massive issue. Hold on a sec. Publications in development. Yes, 2022. Yes, spring. Yes. Clean 15. Here it is. All right, hold on a sec. It's just opening the file. All right. So the Dirty Dozen for 2022, the foods you should only eat organic. You should not get them if they're not organic. Number 1, strawberries, spinach, kale, collard and mustard greens, nectarines, apples, grapes, bell and hot peppers, cherries, peaches, pears, celery, and tomatoes. Basically the thin-skinned fruit. And please note that they're not just testing the skin. They're actually taking the skin off and testing the meat of the fruit. And we're talking about the pesticides inside the fruit, the pesticides that you're giving your children. So if you're going to buy strawberries, please only buy organic strawberries. It's the same with peaches and pears and apples and especially grapes too. The cleanest foods, the foods that they say you can buy non-organic, have the thicker skins: avocado, sweet corn, pineapple, onions, papaya, sweet peas, which are great for fiber. Microwave some peas today, would you? Tonight for dinner tonight, your bowel will thank you. Asparagus, honeydew, kiwi, cabbage, mushrooms, cantaloupe, mangoes, watermelon, sweet potatoes, right? So that's the Environmental Working Group's Clean 15 and Dirty Dozen. Deidre, thank you so much for the 50 stars. I really appreciate that. Very, very much. Thank you. Thank you for thinking of me. Hold on a sec. Deidre says, I'm scared to try new things because everything causes pain, but I'm going to try the coconut butter. Honey, that's where I was in my 20s, when I had really bad IBS. And that's all gone now. I mean, I do not have IBS anymore. I do not have vulvodynia anymore. Now that I have figured out that really that was all being caused by really, really sensitive nerves because my muscles were messed up. Just a neuromuscular process. Once I focused on that, all of my other symptoms went away, including my bladder symptoms. So, carry hope in your heart, my friend. Carry hope in your heart. It's one step at a time. Elizabeth says, I just got back from the fertility specialist and I have the ovaries of a 26-year-old. Yeah, IC did not take that from me. Well, IC wouldn't take that from you anyway. The downside is my periods are so painful and I've tried everything. I just want my uterus removed. Well, this hurt my bladder. Last month, it was so bad, I was considering walking into the ER and demanding a hysterectomy. This is because I can't get any pain control. I tried 15 types of birth control and they don't help me. Jennifer, thank you. Thank you for the 100 stars. So much. Thank you, honey. Thank you for thinking of me. Thinking of the IC network. Elizabeth, you don't say how old you are, hon. I mean, if you are done having children, then having a discussion about a hysterectomy that keeps your ovaries, it would be completely reasonable. I swear, hold on a sec. You know what? I think it was in the European guide. But I read a lot of journal articles every week, so. Okay. It's not where I thought it was. So anyway, I mean, number one, we have to try to understand what's going on. There are some patients who are just very hormone freakily